All right. Hello, everyone. Welcome back to another Rafael Medina subspecialty episode. I'm so thrilled for today's session because it's our first ever maternal and fetal medicine focused subspecialty episode. And it's about time, and I really hope this is the first of many. But I'm so thrilled to have two fantastic people who are helping to make this session happen. I'm really excited to learn from them. So we have Dr. Greg Kirschen, who will be discussing the case. And we have Dr. Mary Peeler, who will be presenting a case. I'll jump into their introductions briefly, and then we'll hear from them a little bit about kind of what drew them to the field of maternal fetal medicine. So I'll start with Dr. Greg Kirschen, who, as I mentioned, he's a current first year maternal and fetal medicine fellow at the University of Pennsylvania. And he has a particular interest in pharmacology and metabolism in pregnancy. And before fellowship, he did his MD PhD at Stony Brook in New York with a PhD in molecular pharmacology, and then did his OBGYN residency at Johns Hopkins. So Greg, thank you so much for making this session happen and being our guest discussant today. You've also presented on VMR before, so a familiar face to many, but just curious kind of how you how you developed an interest in maternal fetal medicine, and then maybe share what you like to do outside of medicine.
Absolutely. Well, first of all, thank you so much to you, Maddie, and the rest of the VMR community and CP Solvers for having me back. I had a blast my first time. I hopefully will be a recurrent guest. So my interest in maternal fetal medicine really started in graduate school, where I was studying embryonic brain development and pharmacology and different receptors that get expressed during embryology, during fetal development, and really drew me to the field of OBGYN. And then I feel like within MFM, we constantly are getting consults for patients who are on complex drug regimens for diseases of a variety of, organ systems, and thinking about how the drugs, how they affect pregnancy, how pregnancy changes metabolism of drugs, how which drugs do and don't cross the placenta. A lot of these are still black boxes for us, and ripe area for research, which is sort of where I feel like my niche is starting to develop. And so I'm really excited to be in the field, and also really excited to be here.
That is fascinating. Such a cool interest, and yeah, thank you so much for being here. Really excited to learn from you. And so our case presenter today is Dr. Mary Peeler, who's a first year maternal fetal medicine fellow at UNC. And she's originally from Memphis, Tennessee, and did her undergrad degree at the University of North Carolina at Chapel Hill. And then she did her medical school and residency in OBGYN at Johns Hopkins in Baltimore. So Mary, thank you so much for presenting the case, and would love to hear a little bit about your story and how you felt an interest in maternal fetal medicine.
Yeah, thank y'all for having me. And thank you, Greg, for inviting me to join. We did residency together and have loved talking about complex cases together. So I think this is going to be really fun. I have a very different path to OBGYN and maternal fetal medicine compared to Greg, which has been something that we've laughed about as we've kind of landed on the same pathway, but coming from very different ends. I'm really interested in population health and public health, and thinking about health disparities, and how social determinants or social drivers of health can impact health outcomes. And I love taking care of pregnant individuals because I think that pregnancy is a really unique time, both biologically and physiologically, but also socially in terms of access to insurance, motivation for care behavior management changes. I have a particular interest in substance use disorder in pregnancy. And I think that it's a population that has a lot of challenges in terms of stigma and policy that's very unsupportive. And it's a time when individuals are more motivated than ever sometimes to make changes that they wouldn't consider at any other time in their lives. And so that's one of the things that I really love about caring for pregnant individuals. And maternal fetal medicine just gives us as OBGYNs more time and fellowship to really understand more both the biology, the physiology, and also the complex medication management, care plan management, to take care of the most complicated pregnant patients before, during, and immediately after their deliveries.
Wow, thank you so much for sharing that. That's what like an incredible interest, and can't wait to kind of learn more from you throughout the session today. So thank you so much for presenting the case. Um, so we definitely have kind of a lot to discuss in this case that Mary will present. So I think we can jump right in. Seema, thank you for scribing today. You can go ahead and share your screen. And Mary, whenever you're ready, you can start with the first aliquot.
Sure. So this patient, RD, she is a 22-year-old G1P0. And for the non-OBGYNs, that means this is her first pregnancy. She's 24 weeks and 4 days. And she came into our labor and delivery triage with a headache and blurry vision. She said that she had intermittent headaches in the past, but had a new one that started overnight. And she tried to take some Tylenol, but it wasn't responsive.
Got it. Great first aliquot, Mary. Thank you. And Greg, and on TB Solvers, we talked about kind of an approach to headache before, but I'm really curious, one, how you approach headaches in general, and in a pregnant individual, how does that influence how you think about the differential?
Absolutely, yeah. So I think, first of all, thank you, Mary, for presenting a case to me. This is a lot of fun already. And I want to say that in general, our approach to headache and my approach to a chief complaint in general within pregnancy is, I think, first about OB causes so that I don't forget to think about the pregnancy and the baby. And then I think about sort of the general internal medicine, rest of the body causes. So whenever we have a patient who's after 20 weeks gestation presenting with a headache and blurred vision, you have to think about preeclampsia on your differential diagnosis, because we know that the placenta, can contribute to hypertensive disorders of pregnancy starting at about 20 weeks, and she's 24 weeks now. It would be early for her to have preeclampsia, where you're usually seeing it later in the third trimester developing. I don't know if she has a history of high blood pressure coming into the pregnancy, but that would be something that I'd be curious about. The blurred vision also is a little bit of a red flag for me, because we know that neurological changes in patients who have hypertensive disorders of pregnancy are associated with the development of eclampsia, which is seizures related to high blood pressure, which is what we're always trying to avoid when we are, diagnosing preeclampsia or, treating patients with high blood pressure disorders in pregnancy. That being said, we don't know that she has high blood pressure at all. All we know is that she has a headache and blurred vision. It sounds like she does have a history of headaches, so I'd want to dive a little bit deeper into that. Does she have a migraine history? Does she have tension type headaches that she's been getting? The other red flag for me is that it's not responsive to Tylenol. So, unlike outside of pregnancy, we are a little bit limited in what we can use to treat headaches during pregnancy. We can't use NSAIDs. We try to avoid opioids just because of, fetal toxicity. So our mainstay of headache treatment typically is, Tylenol. We can use metoclopramide or Reglan. We can use some other antiemetics. We can use fluid boluses, magnesium oxide, Benadryl. That's sort of like our headache cocktail that's safe in pregnancy. So I would also want to know if she's tried any of those to help with the headache. If not, that also kind of makes me a little bit more concerned that this could be a more sinister cause of headache. And then we think about all the the non-OB related causes of headache. So you can think about structural things within the CNS, like a tumor, or other mass, or you could think about any type of compressive brain bleed, things like that, that could cause a acute onset headache. And then more of the more benign causes of headache, such as we talked about, like tension headache, migraine. Or what's the other one? The like ocular headaches that are I can't remember the exact, but or like trigeminal neuralgia, those kind of less serious headaches.
Yeah, Greg, I love that, thinking about kind of etiology specific in pregnancy versus not, and kind of the red flags that you walked through. You mentioned preeclampsia, and for those who don't think about OBGYN on a daily basis, do you mind just kind of clarifying how you make the diagnosis of preeclampsia?
Absolutely, yeah. So preeclampsia is sort of our bread and butter within OBGYN and MFM. So to make the diagnosis of preeclampsia, you have to have there's like formal criteria of 2 or more blood pressures that are greater than 4 hours apart, that are greater than or equal to 140 millimeters of mercury over 90, plus proteinuria, which is defined as greater than or equal to 0.3 protein to creatinine ratio, or 300 milligrams on 24-hour urine protein. That's in that case, that's like sort of the baseline preeclampsia. That's what we call preeclampsia without severe features. Then you can add on severe features, which would include headache, non-responsive to medication, persistent neurological symptoms, blood pressures that are greater than or equal to 160 over 110, which we know are in that kind of eclamptic range, although you can have an eclamptic seizure even with mild range blood pressures. And then other features such as laboratory abnormalities, so platelet count less than 100,000, a creatinine that's greater than 1.1, or other end organ dysfunction. So you can have pulmonary edema, HELP syndrome. Those are all ways to make the diagnosis of preeclampsia. I don't know if I'm missing anything, Mary.
That was so helpful. Thank you so much for going over that, Greg. And I think it'll be helpful for us to kind of have that baseline definition as we think more about this case. Mary, I'll pass the mic back to you for the second aliquot.
Yeah, so in terms of additional information that we gathered from the patient on the first evaluation for her HPI, she has had occasional headaches during pregnancy, usually tension type, and they usually respond to acetaminophen. She's also noticed pelvic pressure and some cramping over the last day, no vaginal bleeding, leakage of fluid. She has been feeling her baby move normally. She denies any history of hypertension or any relevant family history. She says that she's had up-to-date prenatal care to this point, and her blood pressure has been within normal limits at all of her previous visits. In terms of her obstetrical history, which is an additional history item that we always collect in pregnancy, her pregnancy, as I said before, is 24 weeks and 4 days. She was dated by a last menstrual period that was consistent with a 9-week ultrasound. She's been up to date on her prenatal care as to this point, had a normal anatomy ultrasound at 19 weeks. In terms of her past medical history, she has a history of gastrointestinal reflux, and cholelithiasis. Her surgical history is notable for a laparoscopic cholecystectomy that was 3 years ago. No additional surgical history. Her family history is notable for hypertension in her mother. No other additional family history that was relevant. In terms of her social history, let me know if I'm going too fast. The scribe is doing awesome, keeping up. In terms of her social history, she denies any alcohol, tobacco, or drug use during this pregnancy. She previously occasionally used marijuana and alcohol, but discontinued in the first trimester when she discovered her pregnancy. For medication, she's only taking a prenatal vitamin. For allergies, she has an allergy to sulfa drugs listed in her chart. And then in terms of the objective, starting with the physical exam, her vitals, her initial blood pressure is notable for 164 systolic over 89 diastolic. Her pulse is 59. Her temperature is 36.7 degrees Celsius, 98 degrees Fahrenheit. Her respirations are 20, and she's satting 100% on room air. In terms of her physical exam, she's in no acute distress. Her cardiovascular exam is unremarkable, normal rate and rhythm, no murmurs were appreciated. On auscultation of her lungs, she had clear fields bilaterally with a normal respiratory effort. Abdominal exam was notable for a gravid uterus. Fundus was 3 centimeters above the umbilicus. She had no right upper quadrant tenderness, no rebound, no guarding. She was soft and non-tender throughout her abdominal fields. In terms of her neurologic exam, she was alert and oriented ×4. Her cranial nerves were intact. Her visual fields were intact. She had normal strength in all 4 extremities. She had deep tendon reflexes that were 2+ in the upper extremities. In terms of her GU exam, she had normal appearing external female genitalia. She had a speculum exam that noted normal vaginal mucosa. She had a cervical exam performed due to her cramping and was found to be fingertip dilated with a slightly effaced cervix. In terms of her extremity, she had trace pedal edema that was symmetric bilaterally, no calf pain or tenderness. And then in terms of her additional physical exam findings, we include her fetal assessment here in obstetrics. And so her non-stress test of the baby that was performed at this time showed a fetal heart rate of 150 beats per minute with moderate variability, no fetal heart rate decelerations. She had occasional contractions noted on TOCO monitoring. And then she had a bedside ultrasound that demonstrated a viable singleton pregnancy and footling breech presentation.
Thank you so much, Mary. Lots of really rich information here. And Greg, really just want to hear your thoughts overall on this, but some specific things we were curious about. You kind of mentioned your initial concern for preeclampsia and walked through that kind of how to make that diagnosis. And curious how you're thinking about would you classify this patient as preeclampsia at this point? And then the fetal exam as well. What is your interpretation of that?
Yeah, this was a very rich aliquot, a lot of information, and I'm picking up on a couple of key things. So I'm just going to kind of go top to bottom. In terms of her history, she has had tension headaches in the pregnancy. I didn't hear whether or not this is like a singular headache, like whether this is something that's outside of her norm, or you might think about like a subarachnoid hemorrhage, for example, or like a dural venous sinus thrombosis. Um, then in terms of her, the rest of her history, we heard that she was so she had well dated, meaning that we can be confident that she's 24 weeks. You have patients occasionally coming in who, don't know their last period. They haven't had early ultrasound in the pregnancy. You're not sure that they're 24 weeks. You could be further along, which would maybe increase my suspicion for preeclampsia. Although, as I said, it could certainly happen after 20 weeks. But we don't have to worry about that because she's been well dated. Something also important, she had a normal anatomy. One diagnosis that I think of in patients who have early onset preeclampsia and have fetal hydrops, which is basically edema in various compartments of the fetus, including like the under the skin, pleural effusions, pericardial effusion, ascites, is something called mirror syndrome, where the baby and the mom basically both get preeclampsia. But the fact that she had a normal anatomy basically rules that out for me. In terms of her past medical history, it's relatively unrevealing. She has GERD. She's had some gallstones. She had a cholecystectomy that may, if when we get to her labs, we'll kind of take the LFTs in the context of her history of gallstone disease because those are part of the preeclamptic evaluation. Although I'm not overly concerned with that at this point. Family history, she has hypertension in her mom. We know that, there are certain genetic components to hypertension, but it sounds like she's been very normotensive this pregnancy and outside of pregnancy. She has an unremarkable social history. She really hasn't used substances during the pregnancy that I'm worried about, like cocaine, which can increase blood pressure, as we know, within and outside of pregnancy. And then she's only on a prenatal vitamin, so no medications that I'm worried about are causing her hypertension that we'll get to, and no real significant allergies other than the sulfa. Then, when we get to her physical exam, the first thing that jumps out at me is her blood pressure. Definitely not a normal blood pressure anytime during pregnancy, and especially in the late second and third trimesters, where severe range blood pressure, which we would characterize this as with the 164 systolic. I would want to repeat that because in order to really make a diagnosis of severe preeclampsia, you need two values that are in that severe range of greater than or equal to 160 over 110, sustained over 15 minutes, anywhere between 15 minutes and an hour. Then you've made the diagnosis of preeclampsia. Then we move towards treatment to really get that blood pressure under control and start magnesium for seizure prophylaxis. So I want to repeat that blood pressure to kind of see where we're at. If it normalizes, then we can kind of do watchful waiting and see how things go. But definitely something I'm paying attention to. The rest of her vitals are relatively unremarkable. The only thing I'll note is that she's a little bit bradycardic with a heart rate of 59. That makes me a little bit. I'm sort of thinking ahead to treatments that we might give her. Labetalol is one of our mainstays for bringing down blood pressure acutely in pregnancy. We use like 20 milligrams IV labetalol. I'd be a little bit hesitant to use that in her given the bradycardia, so I might choose another agent like oral nifedipine, for example, or hydralazine. Then we get to the rest of her physical exam. She's not in any acute distress. That sounds good. I like that Mary mentioned her abdominal exam, the fact that she does not have right upper quadrant tenderness, because we do know that hepatic inflammation goes along with severe preeclampsia. So that is a little bit reassuring that we don't have an inflamed liver. We get to her neurological exam, which I'm also very curious about in a patient who I'm assessing her blood pressure and who has neurological symptoms. That was very reassuring. The fact that she was not hyperreflexic, for example, reassures me against a physical exam finding of CNS involvement. And then the interesting thing is that she, on her cervical exam, is actually a little bit dilated. That's actually abnormal, especially in someone, this is her first pregnancy. She's only 24 weeks. I would not expect her to be dilated. She's only fingertip dilated, which means that you can basically just get the little tip of your finger into her cervix. But she is also effaced, which means that the cervix is thinned out. And interestingly enough, in patients who have severe preeclampsia, we think of this as sort of a sterile inflammatory condition that can actually cause cervical remodeling and preterm labor. So that actually tips me off that this could be preeclampsia leading to preterm labor, which we do occasionally see. And then we get to a little bit of peripheral edema, which also goes along with preeclampsia. Although we do see, especially as the gravid uterus kind of compresses the IVC, that limits some of the return of blood flow back to the heart, that we can get some peripheral edema physiologically in pregnancy. So I'd want to know like how new that is for her, how severe it is. And then we get to the fetal assessment after that. So with the fetal assessment, I'm actually very reassured. The fact that the heart rate is normal, the variability, which is sort of that beat to beat variation in the heart rate that we see on our monitors, that tells us that the fetus is non-acidotic. And we do worry about acidosis, particularly in patients who have clamtic seizures or other insults that can cause placental ischemia. Or just long-standing preeclampsia can also lead to loss of variability or fetal heart rate decelerations because of a poorly perfused placenta, and she does not have that. Although we do see that she has occasional contractions, which goes along with this possible preterm labor picture. On ultrasound, we found that she has a viable fetus that's singleton, so she doesn't have twins. Twins also, or multiple gestations also increase your risk for preeclampsia. And then the baby's in the footling breech presentation. The reason that's important is we think about mode of delivery. If this patient's going to have to be delivered, does she need a C-section? Can she have a vaginal delivery? Actually, interestingly enough, if you're before 25 weeks, there's actually comparable outcomes between vaginal delivery, breech vaginal delivery and cephalic vaginal delivery, meaning head down. So we can actually offer this patient a vaginal delivery even though she's breech, which is actually very rare. We almost never do vaginal breech extractions for singletons in the United States, but this would be a case where I would actually consider that if we're having to move towards delivery. And I'll stop there.
Oh my gosh, that was just such an expert discussion. My God, I learned so much from you dissecting all of that. Just absolutely amazing. Um, a few questions kind of going into the next aliquot. I'm curious what you touched on this a little bit, but what specifically are you going to be keeping close attention to on labs that you get?
Absolutely. So the things that we care about with labs, sort of like preeclampsia labs, we call them, are typically a CBC, a CMP, and a urine protein. On the CBC, we're looking for anemia, which can be an indicator of hemolysis. We're also looking for thrombocytopenia, which could be from platelet consumption, and microangiopathic hemolytic process. On our CMP, we're looking at her renal function because we know that renal impairment is one of the severe features of preeclampsia. We're looking at her liver function tests because those are also, you can have hepatic inflammation, as I mentioned. And then on her urine protein, I'm looking to see if that's greater than 0.3. Although, honestly, we see patients with preeclampsia who meet criteria by other features. They don't need proteinuria to make a diagnosis of either mild or severe preeclampsia. Mild, you need the proteinuria, but severe preeclampsia, you don't need the proteinuria. So those are the things that I'll be tracking as we hear the next aliquot. And of course, I would want to potentially, if we think that there's another etiology, think about cerebral imaging as well.
All right, absolutely amazing discussion. Thank you. Mary, we'll pass the mic back to you for the next aliquot.
Great. Yeah, Greg, you're doing all of the same thought processes we had as this patient came in. So for her initial labs, we got a CBC. Her white blood cell count was 14.5. Her hemoglobin was 13 with a hematocrit of 36. Her platelets were 12. Her CMP was as follows, with a sodium of 138, a potassium of 4.6, chloride 104, bicarb 23, anion gap of 6, glucose 115, creatinine of 0.5. AST and ALT were 34 and 19, which is within normal limits at our laboratory. Her bilirubin was 1.8, which is slightly elevated at our laboratory, and her alk phos was 143, which is elevated at our laboratory. Her urine protein to creatinine ratio was 3.53. Her uric acid was also sent, which was 6.2, which is normal at our lab, and her LDH was 725. The upper limit of normal at our lab was 271. She had a type-in screen that was sent that was O positive with antibody negative, and she had a urine toxicology screen collected on admission that was negative. She had an RPR and a rapid HIV that were also negative. That was our first set of labs we sent off.
Thank you, Mary. Yeah, Greg, what stands out to you in this initial lab work?
Yeah, so a couple of things jump out at me right away. That platelet count of 12, whoa, that's low. I always think about, so in pregnancy, you can have a little bit of what we call gestational thrombocytopenia, where pregnancy in itself is a hemodilutional state. So you're going to increase your plasma volume by 50%. And so all your cell lines are going to go down a little bit, but definitely not that severe. And you can see the rest of that's certainly out of proportion to her white blood cell count and her hemoglobin. The hemoglobin of 14, we also see a little bit of like physiological leukocytosis. There's some demargination of neutrophils in pregnancy. Hemoglobin 14 catches my eye a little bit, kind of, I think of like 12 to 13 as kind of upper limit of normal in pregnancy. The hemoglobin of 13, now that is interesting because in pregnancy, we're typically seeing hemoglobins that are at highest around 12, maybe 13. I suspect she might have a little bit of hemoconcentration, which goes along with preeclampsia. That might also explain why we're seeing an apparent leukocytosis. And oftentimes we see patients who are severely vasoconstricted with preeclampsia, and it'll look like their hemoglobin is really high when it actually in reality it's normal or even low. So that's something that I'm paying attention to. The fact that her platelets are 12 and she's hemoconcentrated, her platelet count might even be lower than 12, I'm worried about. So that's one thing that jumps out at me initially. Then I look at her creatinine is normal. The rest of her, electrolytes look okay. Her liver function tests are within normal limits. The bili is a little bit elevated. I would want to know whether that was predominantly a direct or an indirect hyperbilirubinemia. Her alk phos is 143. Actually, in pregnancy, that's normal. We know that the placenta excretes alkaline phosphatase along with the hepatobiliary system, so that doesn't catch my eye at all. I'm fine with that. Her urine protein is sky high, so 3.53. That's like 10 times the upper limit of normal. So that definitely is something that is tracking with the principal differential diagnosis that I'm considering. Although there can also be other now I'm starting to think of, is there, any type of nephrotic syndrome going on in the background that's maybe that was undiagnosed prior to pregnancy that's leading her to have preeclampsia, because even for a preeclamptic, that's a high UPC. And then her LDH is also high, which goes along with this probably hemolytic process. And then her type and screen, not too concerned about. She was antibody negative, so we think that there's probably not an alloimmunization type of picture going on. Her urine toxicology was negative, so not a drug component that's contributing to this. And then I like that Mary included her HIV because we do know that HIV can cause thrombocytopenia, although I would not think it would be that profound. But regardless, it's negative as well as her syphilis test.
Yeah, again, absolutely, just brilliant discussion. One question I wanted to ask was a little bit about management, and you talked in the last aliquot, some things like magnesium, labetalol for blood pressure control. I know we don't have kind of a repeat blood pressure measurement, but say we did get a repeat blood pressure measurement at that interval you mentioned, and it was still elevated. Would you be giving magnesium, labetalol, anything else you would be doing from a management perspective with suspected preeclampsia?
Yeah, that's a really good question. So if she has persistently elevated blood pressures, which I would, kind of assume based on the rest of the information I've received so far that she would, first priority is get that blood pressure under control, because we know that that's really the time critical thing is getting the blood pressure into the normal, either at least into the mild range, if not normal tensive, and starting magnesium for seizure prophylaxis. So those are the number one and number two things that I'm doing simultaneously as I'm evaluating this patient. As I said, for her, I would want to know, does she have IV access? If she does, I would want to repeat that heart rate just to make sure we're safe to give labetalol. If she doesn't have IV access, we can give 10 milligrams of PO nifedipine, or once she gets an IV, we can also do 5 or 10 milligrams of IV hydralazine. And we have ACOG, our professional body, has guidelines for management of preeclampsia with different blood pressure pathways. So, for example, if you're on labetalol pathway, you give 20 milligrams, you check it in 15 or 20 minutes. If it's still severe, you give 40 milligrams, then you check another 15 minutes. Still severe, you give 80 milligrams, then you go to hydralazine. And there are different pathways for each of the starting medications. So it actually is important which medication you give to start, because that'll dictate the rest of the pathway. So you're always thinking about, do they have any contraindications to getting one of these medications or another? For example, with labetalol, if they have severe asthma, I'm also going to try to avoid it. I'd switch to nifedipine. I'd start with nifedipine or hydralazine. If they're tachycardic, then I'm probably going to avoid nifedipine because it can cause a reflex tachycardia. So those are, some of the things. If they have a history of like drug-induced lupus, I'm going to try to avoid hydralazine. those are just like some initial thoughts. And then so that's like maternal management, getting the blood pressure under control, starting the magnesium. And then for fetal management, the magnesium is actually also protective for the fetus in case this is going to be a preterm delivery, because we do know that magnesium sulfate crosses the placenta and stabilizes some of the periventricular area of the brain and can help prevent CP or cerebral palsy that's caused by premature delivery, not necessarily the preeclampsia itself, but the prematurity that goes along with being born in the context of severe preeclampsia. So that's also fetal protective. And then I would keep her on continuous fetal monitoring because we want to make sure that the baby continues to do okay.
Thank you so much. That was a super interesting discussion. And going back to kind of the thrombocytopenia that really stood out to you. So you mentioned kind of on the differential preeclampsia with severe features. Are there other things you're considering for the patient's thrombocytopenia, or is it really preeclampsia with severe features that's top of mind?
Yeah, there are definitely other differentials that I'd be considering. So I think about like TTP, HUS, atypical hemolytic uremic syndrome. We've seen these types of cases before that kind of masquerade as preeclampsia. And we oftentimes, if we're suspicious that it's an alternative etiology for this, I'm putting the whole picture together. We have a patient who's G1P0. Being a prima gravida also increases your risk of preeclampsia in and of itself. But the fact that she's 24 weeks, like everything is a little bit out of proportion for me for preeclampsia. The fact that she's only 24 weeks, she's having severe range pressures, her platelets are 12. That's on the end of very severe. This is getting into HELP syndrome now. Or we can start thinking about other. Largely, I'm thinking about renal and like blood related pathologies, like hematological processes like HUS that could be contributing to this as well.
All right, absolutely amazing discussion. Mary, we'll pass it back to you for the next LQAT.
Yeah, so with the next set of information, I'm also going to give a little bit more of the clinical history. As you alluded to, we did continue to repeat the patient's blood pressures, which were continuously elevated within the severe range. She received IR nifedipine to bring down her blood pressure back below 160/110, which is our goal in pregnancy to reduce the risk of stroke. She received magnesium sulfate for presumed preeclampsia with severe features by blood pressure and platelets. Her headache did resolve following metoclopramide and IV magnesium administration. However, her fetus started to have less variability, and there was concern for fetal distress. She was counseled on delivery options with a recommendation for delivery given the inability to rule out preeclampsia with severe features that could worsen. And she opted for cesarean delivery under general anesthesia. She had a classical cesarean incision due to the early gestational age and underdeveloped lower uterine segment. She delivered a live-born male infant that was 840 grams. The total blood loss from her surgery was 650 milliliters. The surgery was overall uncomplicated. We repeated her labs on post-op day 1, which were notable for a white count in her CBC. Her white count was 20.5, hemoglobin was 6.4, hematocrit was 18, her platelets were 42, her reticulocyte count was 5.6, and the upper limit of normal was 1.6. She had a manual smear performed at this time that showed red cells with 1+ schistocytes. There was a neutrophil predominance without a significant left shift. Her platelets were subjectively decreased on the manual smear, and no circulating blasts were appreciated. Her CMP was also repeated the next day. Her sodium was 138, potassium 4.1, chlorine 104, CO2 23, anion gap was 4, her glucose was 89, her creatinine was 0.9, AST and ALT were 37 and 37, both normal. Bilirubin was 1.2. Her alk phos was 72, which was normal. She had coagulant that had a fibrinogen of 355, PT-INR of 13.5 and 1.0, APTT was 27.5. Her LDH was now 356. She had a direct antiglobulin test that was negative. We repeated her labs. I'll give just one more set on post-op day 2, which was notable for hemoglobin of 7.8 after she received 1 unit of packed red blood cells. Her platelets were 22. Her reticulocyte count was 4.8. She again had a manual smear, which showed platelets that were decreased in number with normal morphology. There was no clumps or fibrin strands noted. Her red cells showed some basophilic stippling, occasional red cell fragments, and nucleated red cells. And her leukocytes showed leukocytosis with neutrophilia. Her LDH at that time was 596, and her haptoglobin was less than 10. So she has this, platelet trend of 12 up to 42 after delivery, and then on post-op day 2, back down to 22.
Yeah, thank you, Mary. This is again lots of really interesting data. I'm curious, Greg, your general thoughts. One specific question, if I could ask, is Mary highlighted kind of this persistent thrombocytopenia even after delivery, and was curious. I know we can talk through your overall thoughts, but if you have these low platelets from preeclampsia with severe features, would you generally expect that to resolve after delivery, or can it persist even after delivery?
Yeah, it's an excellent question. So, in general, the treatment for preeclampsia is delivery of the placenta. So, delivery of the fetus and placenta typically causes resolution of the preeclampsia. That being said, we don't expect the platelets to necessarily recover until really 48 hours plus. So I'm not, too surprised that her platelets are still low even after delivery, even up to, post-op day 2. Although it does look like they're sort of trending in the right direction. But yes, so I feel like there's a lot of other things to talk about. Do you have any other questions? I can kind of jump into the rest of this aliquot.
No, yeah, please feel free to discuss anything that stands out to you.
Awesome. So first of all, I want to say, just like take a pause and say that Mary, this must have been a really challenging case. It's never an easy decision to deliver a 24-weeker. The implications, this is really peri-viability, where the baby potentially could survive on the outside, but it's going to be a very rough NICU course. They're probably going to be hospitalized for months. The baby is at risk for cerebral palsy, even with the magnesium, risk for bronchopulmonary dysplasia, risk for a necrotizing enterocolitis, poor neurological outcome, death. Really, like, these 24-weekers generally, it's a very guarded prognosis. So we don't deliver these patients lightly. That being said, I completely agree with the decision to move forward with delivery, given how sick this patient is. It looks like you were able to bring down her blood pressure to the mild range, which is good. Her headache resolved. If her headache hadn't resolved, that actually in and of itself would be an indication for delivery, because that's a persistent neurological symptom, not responsive to medication. The fact that you also saw some evidence on the fetal heart rate tracing that there was decreased variability in the heart rate, that to me suggests that there's starting to be some fetal acidosis, which is likely from placental insufficiency. So again, goes along with this picture of like a worsening preeclamptic state. The fact that you opted for cesarean delivery, I think, makes sense, given that you have to go quickly. And these patients, especially, if they're early, mid-second trimester, even up to like 36 weeks, these are going to be prolonged inductions for the most part if you're going to try to get this patient to a vaginal delivery. Severe preeclampsia in and of itself is not a reason that you need to do a C-section. Let's just make that clear. But in a patient that you're very concerned about, who you think is going to decompensate quickly, I think I would totally agree with the cesarean as mode of delivery. The fact that it was done under general anesthesia makes sense because of her platelet count. So you have to think about the fact that, an anesthesiologist is not going to want to place an epidural or a spinal in a patient with a platelet count of 12. Typically, according to the anesthesia guidelines, depending on who you ask, also there's some attending preferences, but anesthesiologists I've worked with mostly will say that they're comfortable placing an epidural if the platelet count is above 70 or 80. Hers are definitely nowhere near there, and I also wouldn't transfuse platelets just to get her up to that point, because we know that they're you're probably going to get consumed by this consumptive coagulopathic process. So that's number one. The fact that she had a classical C-section, what that means is that it basically is an up and down incision on the uterus. She probably still had a Fannin steel incision on the skin, so that's that kind of like bikini line incision. But on the uterus, we oftentimes will do what we call a classical incision, just because the lower uterine segment, which is where we typically will make our incision, is just underdeveloped at this early in gestation. The reason that this is important is just because for all future deliveries, she will need a C-section. There are most cases actually of patients who have a normal, let's say full-term C-section, who have a low transverse incision on the uterus. They can try to have a vaginal delivery in the future. She will be, committed to cesarean deliveries from here on out, starting, between 36 to 37 weeks. But that's sort of an aside. The baby was 840 grams, so that's actually something good. Good piece of advice or good piece of news, because we know that babies that are less than 500 grams have extremely poor outcomes, because the intubation equipment that the NICU uses really doesn't get smaller than about a 500-gram fetus. So the fact that it's 340 grams greater than that minimum doesn't necessarily mean it's going to do well in the long run, but definitely should be resuscitatable at least. And it was normal blood loss. And then we get to the labs on post-op day 1. We see that she has a little bit of a leukocytosis, not unexpected for someone who's just had major surgery, which we consider as a C-section. So I'm not, too worried about that leukocytosis. I see that this was her true hemoglobin was 6.4, which is sort of what I was expecting when I saw, 13. That didn't look right to me. So I think her true hemoglobin was probably somewhere around like 7 or 8 coming into the hospital. She was hemoconcentrated. She had the C-section. She lost 600 cc's, which is a very typical blood loss, actually, a little bit on the lower side, honestly, for a C-section. So that's very dry C-section, in my opinion, especially for classical. Classicals, we usually see higher blood loss compared to like low segment transverse C-sections, just because it takes a long time to like bring that muscle back together. Her platelet counts recovered a little bit to the 40s. And then her reticulocyte count is high, which is, her bone marrow is appropriately responding to her anemia and her thrombocytopenia, trying its best to pump out those cells. We know that this is probably not a primary bone marrow process. So that makes me reassured, at least from that standpoint, that her bone marrow is working appropriately. On the smear, the one thing that stands out most prominently is the schistocytes, which tells me that there's evidence of a microangiopathic hemolytic process. So there are these probably like platelet microthrombi within her blood vessels that are shearing some of these red blood cells. Goes along with why her platelets are low. They're causing these clumps all throughout her system. And then I saw her fibrinogen was normal. I can't remember where the rest of her coagulopathy studies were within normal limits as well.
Yeah, they were.
Okay. Yeah. So that makes me more reassured that she's not going into DIC, which is something that certainly can happen when you're starting to consume your coagulation factors and your platelets. And typically, in pregnancy, our fibrinogen should be a little bit on the higher side, but we typically, I start getting concerned when the fibrinogen is less than 250, let's say, definitely less than 200, very abnormal at any trimester of pregnancy. And there are actually nomograms for fibrinogen levels throughout the different trimesters that you can reference, but 355 is totally within normal limits for me. Her LDH is starting to come down a little bit. It was in the 700s, now it's in the 300s. So it seems like some of this process is starting to resolve now that the fetus and the placenta have been delivered. She had a negative direct antibody test, so we think this is probably not caused by like a secondary antibody that's leading to hemolysis or platelet dysfunction. And then her hemoglobin, it looks like bumped appropriately to 7.8 after her red blood cell transfusion. We typically expect the hemoglobin to bump by about a point for every unit we give. If it had not bumped appropriately, I would be concerned that there's ongoing hemolysis going on that that we're not capturing, or that that we have to think about. And then her platelets are gonna, as I said, they're gonna bounce around a little bit the first couple of days. I would expect the overall trend over the next few days to be sort of on the upswing.
Yeah, brilliant breakdown of that data here. And curious, like how you are thinking about the differential right now. What is kind of highest on your differential? What do you think might be going on, and what would you do next?
Yeah, so definitely my differential, I think the fact that she had the high blood pressure in the beginning definitely makes preeclampsia or HELP syndrome top of my list. But then I'm still thinking about TTP, HUS. I would definitely at this point be consulting hematology, seeing if they wanted any additional studies. I think those are probably my top differentials given the whole clinical picture. As I said, I have low concern for DIC at this point, which can be caused by a variety of factors, but definitely, a consumptive coagulopathic process is she's still at risk for, certainly. So this is still a critically ill patient. Don't get me wrong. Those would be my thoughts. But I think like the top differential at this point would still be probably HELP. I mean, I also think about infections that could potentially lead to this, like some type of like tick-borne illness can cause thrombocytopenia, and usually wouldn't be this profound and cause these other derangements. Or you could think about like malaria, intrahepatic, or intra RBC pathogens that can cause dysfunction. I would also think about like these are more rare, but like a hereditary spherocytosis or other problems with the red blood cell membrane that could be causing her to have these schistocytes, and then platelet microthrombi from a more of like a structural RBC issue, but those would definitely be lower on my differential.
Amazing. Yeah, really outstanding discussion. Mary, we'll pass the mic back to you to hear what you all did next.
Yeah, so thank you, Greg. This is great. I love hearing things through a fresh set of eyes. So I think that we were thinking about this very similarly. Our team was very hopeful that delivery would have resolved preeclampsia with severe features. We expected her platelets to rebound. Her blood pressures did improve significantly after delivery. We sent an Adams TS13 on post-op day 2 when her platelets remained at around 20, which takes several days to come back. So that took about 5 days to come back in our lab. And so in the meantime, we did consult hematology, who was concerned based on their review of the smear for a TTP type picture, which is how we sent the Adams TS13. Her platelets continued to drop over the next several days, went down to 16 on post-op day 5. We kept her for daily labs. So as we were awaiting the Adams TS13, we started treating her empirically for TTP with steroids. And had her set up and prepared for plasma exchange or plasmapheresis if her platelets continued to drop. The Adams TS13 did return after several days and was 8. Normal is above 80%, and so that was confirmatory for TTP, actually, as the etiology of her thrombocytopenia. We, per hematology's recommendation, also sent an Adams TS13 antibody to assess whether this is congenital TTP presenting in a 22-year-old or whether this was acquired or autoimmune TTP. Her antibody was negative. So this was actually a congenital case that presented for the first time at an older age and was negative. Given our concern for periviable preeclampsia, we had also sent an antiphospholipid antibody panel, which was negative. So as the kind of final big reveal, this is a masquerader of preeclampsia, and this patient had a confirmed diagnosis of congenital TTP that presented for the first time at 24 weeks of pregnancy. In terms of her ultimate treatment, she received caplacizumab, which is a new monoclonal antibody used to treat TTP. It binds the von Willebrand factor, preventing it from interacting with platelets. So it basically prevents platelet destruction and consumption and reduces the adhesion and allows the platelet counts to rebound. It is quite expensive, but it is less expensive than plasmapheresis. So it's now a new treatment that I hadn't known of or used prior to this. And so she was discharged 2 days after starting the caplacizumab with a platelet count of 400.
Wow, Mary, really like fascinating kind of how this case evolved. And maybe we'll pass the mic to Greg just to hear your initial reflections, and then we can hear from Mary just what it was like taking care of the patient.
Yeah, this is a fantastic case, Mary. Thank you so much for presenting it. Yeah, there's so much rich data here. There's a lot of learning points. It's good for me to know. I actually didn't know if like the Adam TS13 would be high or low. So it's good to know that if it's low, then that's concerning for TTP. I think the decision to start the steroids prior to getting the diagnosis also makes sense for the platelet count, because we have to think about this patient just had major abdominal surgery. She has a lot of surgical beds that are at risk for bleeding. And her platelets are 16. So that's something we always think about as surgeons are, keeping that platelet count at least above 30, ideally above 50, to prevent, surgical rebleeding, because it's going to be very difficult to manage that if she starts bleeding into some of her surgical beds. So yeah, I like that. I like that you're also thinking ahead, starting to get plasmapheresis set up, which can take a couple of days, and then getting all the right teams involved. So I think that was brilliant management. I like also that you sent the APLS workup, because we know that patients with early onset preeclampsia may have antiphospholipid syndrome. So that's something to think about for her next pregnancy. Should she be on Lovenox? It looks like her panel was negative, so we can rule that out. And she has more of this congenital case of TTP. The last thing I'll say that actually I will now add to my illness script for TTP is that it can present with high blood pressure in the presence of normal kidney function. So that's something I never thought about. Like, the way I typically think about it is, if I see elevated blood pressure, it's preeclampsia until proven otherwise. If I see all these other things and it's normal blood pressure, then I'm thinking more TTP. Unless we have renal impairment, then that rule kind of falls away because we know that patients with renal impairment can get kind of sort of like a renovascular hypertensive picture, and that can be clouding the picture. So for me, a learning point is definitely that, the presence of severe range blood pressures does not rule out TTP.
Yeah, and this patient, I think, had a really, did not read the textbook, had a very confusing picture in her initial presentation. Of course, TTP can present with headaches, and that's more classic. She had this new proteinuria. She had had no history of any renal difficulty in the past and no history of proteinuria. And so all of those things had pointed us towards preeclampsia. And in a patient at this gestational age, it's very hard to rule out preeclampsia, and we know that preeclampsia will significantly worsen until the time of delivery. And so the decision to deliver her, as Greg said, we did not take lightly given the periviable gestational age, and we involved the patient in that decision. She was coherent through all of this. But I think that the biggest takeaway from me, and this is what Greg led with at the beginning, is that pregnant patients, the reason I love maternal fetal medicine is they can have everything that a non-pregnant patient can have, plus additional pathology that's possible because of the pregnancy. And so I think that we have to stay on our toes. I love this type of clinical problem solvers keeping me up to date on medicine, because of course, pregnant patients are just patients that have a pregnancy. And so keeping a really broad differential, doing the things that we know in OB can improve our obstetrical specific outcomes, but still thinking about all of the other things that can possibly go into somebody's case, and making sure to use our consultants. And the hematology team was super helpful and very key in helping us get to this diagnosis. We knew something was wrong when her platelets continued to stay so low, but we really needed to lean on support from our consultants. Another point that I'll just add as a learning point for a lot of people that aren't in obstetrics is after delivery, this patient was highly, highly motivated to breastfeed. And so she wanted a lot of information about her medications, risks with breastfeeding. Caplacizumab is not well studied in breastfeeding, but is likely safe. So we had her pump, and then we've referred her to one of the lactation pharmacologists that works at our hospital to give her more information so that she can establish her milk supply while she's on the medication, even if we don't want to give it directly to the infant at this point. Because at such an early gestational age at 24 weeks, she has to work usually pretty hard to establish a milk supply. And if she doesn't pump in the first few days as she's taking the caplacizumab, she'll not be able to establish a milk supply for later.
Mary, can I ask you one quick question?
Of course.
I'm very curious, kind of like retrospectively, now that we know the diagnosis, with not preeclampsia, do you think it was still the right decision to go ahead and deliver her? Or would you, let's say,
Yeah.
you had more time, you kept her pregnant for a week, the test came back, would you still have delivered her?
Yeah, it's a good question and it's a hard question, but I think no. TTP does not improve with delivery. And in fact, it would have been safer for her to have a surgery when her platelets were higher, and certainly would have been safer for the baby to stay in utero. I think that her clinical picture was so concerning for preeclampsia. It was impossible for us not to rule out preeclampsia, basically. And given that, it only took time for us to establish the diagnosis of TTP. But had we known, had she had a previous episode of TTP anytime in her 22 years for her congenital TTP to present prior to this, certainly the best case scenario would have been to avoid delivery, given her plasmapheresis, allow her platelet counts to come back up, and wait into the pregnancy. Yeah, that is a really important point, that preeclampsia is resolved with delivery, but TTP does not improve with delivery. And in fact, optimizing maternal health prior to delivery is the best management.
Thank you. That's great.
Yeah, really amazing teaching and reflections, Mary. Thank you so much. One additional question, kind of for both of you to answer, whichever one has kind of thoughts on it, is I'm curious about kind of the proteinuria in this case. And my understanding of kind of TTP and non-pregnant individuals is I don't associate that with like really significant proteinuria. So I'm curious how you were thinking about the proteinuria in this case. Did you think that was a manifestation of TTP or potentially preeclampsia with severe features? Just how were you thinking about the etiology of the proteinuria?
Yeah, I would say for me, high proteinuria is not part of my illness script for TTP. It's more like increased creatinine, like impaired renal function, which can go along with a little bit of proteinuria, but usually not to this severe degree. So definitely preeclampsia would be higher on my differential with regard to the proteinuria. Although I have to admit, I would have to do more reading to see, how many what percentage of cases of patients with TTP present with proteinuria and a plus or minus renal impairment.
Yeah, and I will say that I think also there were a few things that were a red herring for us. The dramatic hypertension, the proteinuria, that points anyone, especially obstetricians, right to preeclampsia. That's very classic. Buried in kind of a lot of the labs that I gave the patient did have a bump in her creatinine after her delivery. So she went from 0.5 pre-delivery to 0.9 post-delivery and did go up to, I think, 1.0 or so 2 days after delivery. It's a subtle change and could certainly be explained by her significant anemia and just under perfusion of her kidneys, but I think that she may have had some renal impairment that was subtle. An important point just generally in pregnancy is that Greg already has brought up some of these things. Our normal lab values in pregnancy do differ for many labs. Some things are universal, some things are always, obstetricians look at it with a different eye. So Alk Phos he talked about is always elevated in pregnancy. That doesn't get our attention. Creatinine, because your GFR increases so dramatically in pregnancy, creatinine is always lower in pregnancy, and the range of normal is much lower. This patient was very small. We did not have a baseline creatinine on her, but she weighed maybe 100 pounds. So I anticipate in pregnancy, her baseline creatinine was probably 0.35, 0.4. And so getting up to a creatinine of 0.9 after delivery for her is actually a significant change. It's doubling from her baseline of 0.5 that we had. Even though 0.9 is normal, in a normal non-pregnant patient, 0.9 is a pretty high creatinine in pregnancy, even for a person with a lot of muscle mass. So you can have subtle changes that can tip you off, but I think that was very subtle, and certainly the proteinuria pointed us more towards preeclampsia than anything else.
Yeah, thank you so much for that explanation. We have basically 1 minute, and so just as a wrap up, first of all, just want to just huge thank you to you both for truly kind of an expert discussion, Greg and Mary, just presenting a case in such a rich fashion that allowed for such great teaching, and really love your reflections at the end. As a wrap up, Greg, I'm wondering if you wouldn't mind highlighting, 1 to 2 teaching points you want people to take away with from the session.
Yeah, no, this is great. First of all, thank you so much for having me on. This was like so much fun, and getting to discuss it with my close friend Mary was even better. I will say for teaching points, I think for the non-obstetrician, you guys see blood pressures in the clinic that are like, oh, like it's 150, it's 160, we'll get that down, they'll be fine. For us in obstetrics, that's like a big deal. So any blood pressure that's greater than 140/90 should, get your antenna up that something is awry. Especially if it's after 20 weeks. If they come into the pregnancy with chronic hypertension and they're living in the 140s, 150s outside of pregnancy, I'm not too surprised if that's still the case once they're pregnant, although we do know that physiologically there will be a dip in blood pressure that kind of naters around like the mid-second trimester. And then so that's number one. And then I think for preeclampsia, just thinking about the warning signs that we talk about. So headaches that aren't responding to any medications, blurred vision, right upper quadrant pain, shortness of breath, chest pain can be evidence of myocardial ischemia or pulmonary edema. Any worsening of their swelling, as I talked about, there's a little bit of normal swelling that happens in pregnancy. If a patient says I've gained 10 pounds in the past 2 weeks, that's a red flag for me. So I think for the non-obstetrician taking care of pregnant patients, either on the outside, outpatient or inpatient, those are things that you should be consulting OB for.
Amazing. Thank you both so much. We will end the session here. And again, huge thank you to Greg and Mary for truly an outstanding session. And I learned so much.
Thank y'all for having us.
Thank you so much.
Have a great day, everyone.